Hi, folks. I'm Dan Dworkis, and this is the Emergency Mind podcast, a space where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. My guest this episode is somebody I'm happy to call a friend and to reconnect with after a while is Joshua Feblowitz. Joshua is a board-certified emergency medicine physician with training at Harvard University, MIT, and Harvard Medical School, and residency training in emergency medicine at Mass General Brigham, which is where he and I work together. He's a practicing emergency physician and the vice chair of emergency medicine at Frederick Health Hospital, and he serves as a senior clinical and medical editor at Full Code Medical Simulation, and also provides expert consulting services in emergency medicine. Joshua, welcome to the podcast, man. Happy to have you.
Thanks a lot. Thanks for having me, Dan.
Yeah. It's been really fun watching from afar what you've been building because you've taken very interesting path through the world of emergency medicine, which combines this like at the coalface doing medicine, and then this whole arc about training other people in a very unique way, which I'm sure we're going to drift into. But before I put words in your mouth, do you want to give everybody a brief overview of what you spend your time doing and what life is like?
Yeah, no, absolutely. First and foremost, right now I am a new dad for the second time. I'm a 1 month old and I've got a 4-year-old and I've got 3 rescue dogs. So the chaos factor is a little bit high. And my wife would tell you that I wear a lot of hats, and those are just the ones to start. And clinically, I work about 3/4 in emergency medicine, and I'm also the associate director of the department. And it's a big community shop in Maryland. It's not a trauma center, but pretty much everything else under the sun, and super busy, like 200 arrivals a day. So always keeps me guessing, and really interesting and gratifying population to work with in Frederick, Maryland. And then I also have been involved with Full Code, which is a simulation company that offers virtual simulation on mobile devices, your phone, tablet, laptop, whatever, virtual simulations in emergency medicine and pre-hospital medicine to clinicians in training, learning how to essentially do medicine in an experiential way that sticks with you. But you can practice on imaginary virtual patients on an app before you jump into the real thing. But that's also a big chunk of my time. And then I also do legal consulting, which has really sharpened my own practice and taught me how to think about things in a different way. So it's a lot. And when I read it back, I'm like, I'm not sure where I put all that stuff, but it's a great deal of fun too.
It's always interesting to see people that have taken multiple different lenses and applied it to the same sort of craft. So there's the physically seeing the patients, there's training people, there's the legal aspects of it. It's cool to see the different lenses on that. What made you get into it that way? Why did you move from where all of us started, which is and this is air quotes on this, but just seeing patients, to doing this whole mix of things?
Yeah. Full Code started even when I was in training. I've been working on that for a long time now, almost I think eight or more years, doing that in residency and afterwards. But it's, I've always loved seeing patients in the puzzle and trying to figure it out. And especially in emergency medicine, seeing someone for the first time and trying to understand what's going on with them. But I've also had that entrepreneurial bent and teaching experience where I really want to help others understand how to do that. I want to reach a wider audience because it's amazing and gratifying to work one-on-one with patients, but at the same time, really great to share with others how to learn medicine, and whether that's for trainees, either in my own circle and environment or all around the world, which is what we do on the simulation platform. So yeah, I've always had a teaching streak and an entrepreneurial streak that's gone on a ways back. So I really naturally gravitated to those activities as I got more comfortable with my own clinical practice and more advanced.
Yeah, you see this arc sometimes of I get really good at my own domain, and then I get really curious at the domains that are next to it. Right? I think there's a natural spread in emergency medicine between emergency medicine and, let's say, operations, where you realize very quickly, wow, okay, when operations don't work, or when logistics don't work, or supply chains, or whatever it is, it's really hard for my team to do its job effectively. So you drift naturally into solving those next problems or those upstream problems. It's a slightly different arc that takes people through training. And I would argue maybe even different arc that takes them into sort of the broader based sort of medical education that you're doing. Because it's one thing to train the person next to you because you need them, and it's very visceral if they do their job well or not. But this concept of I'm going to do medical education in a broader sense is pretty interesting. So tell everybody about Full Code. What's it like? What's it do? And then we'll walk our way through that space a little bit.
Yeah, no, absolutely. As I mentioned, I've been working on that project and platform for coming up on a decade pretty soon. It's great fun. We're essentially a virtual simulation platform working to make better clinicians of all different types all around the world, with the idea essentially that the knowledge, the medical knowledge, how to practice medicine is hard won and it's hard to learn, but it's not a secret, and it's something that's for everyone, and we want to be accessible to everyone, regardless of your training background or your practice environment or the country that you practice in. Obviously there's differences in local practice, but being able to reach many different audiences and share with them kind of, this is the typical standard of care, what we do with chest pain, with heart attacks, with all manner of different diagnoses, infectious disease, toxicology, and getting comfortable with the actual experiential learning of walking through those steps. So that's what the platform is. You're not getting a multiple choice question. You're not getting a textbook chapter to read. You're getting a patient in front of you that's virtual. You don't know what's going on. And you can interact with them either through an AI powered interview or just taking the history through the app. And then you choose what to do. And you think about what they need and what you're trying to figure out, what tests you run, what results you get back and how to interpret them, and then what to do with the patient, who you need to call for help, and where that patient needs to go, which is just like real life emergency medicine. And the idea is that you're not going to know every time. You're not going to be perfect right up front. You're going to make mistakes, and you're going to iterate on it and be able to practice again, see that patient again, come and look at other similar types of presentations, and take that experiential learning and then apply it in the real world and be comfortable when you see many different flavors of dizziness, of chest pain, of what have you. When you see that rare toxicology poisoning that you only read in a textbook, not just, aha, I know the answer, because that's the simple part. It's all the other steps that come with it. How do you take care of that patient, and what do they need? It's been great fun, and we build each and every story really with a lot of care and attention to show learners the steps that to take and to give them feedback on how to learn and continue to improve. So it's really designed to be for someone that can pull out your phone or any device and run through a case at any time. Sometimes it's on shift, on a commute, at home, in a dedicated study session, but you're really able to access that in any domain. And it's more attuned to what we actually do, the seeing of patients and the figuring out of puzzles, rather than looking at it the other way from just learning from textbook reading about a specific condition.
Yeah, okay, I'm not sponsored at all by Full Code, but I highly recommend it. I think if you're listening to this, you should try it. It's really fun. It's also really interesting as a vector for learning, right? Because one of the problems that we have in emergency medicine, that we have in a lot of fields that we focus on the podcast, is you have things that are complicated to learn. There's a large body of knowledge to master, but then you're mixing that into situations of deep uncertainty, compressed time frames, high impact, and like complex interactions between multiple systems. So the method of, or the problem set of, how do you teach somebody to be a member of that community that works that problem is really real. And we've explored on the podcast a number of different ways that people do it, right? Either through simulation, through graduated responsibility and graduated pressure. There's been a lot of folks that, like you and I, have trained together who've talked about our training and reflected on it. But what I think is interesting about this is that it gives you the space to sort of roam, right? So you're not saying, here's a very specific tiny facet of this thing, what do you do? But more of, all right, show your thought process and what do you do with that? And it allows you to take paths in there that might lead to better or worse outcomes depending on what you do. So I have a couple questions about how you all structure this. And if we drift into anything that's a trade secret or something, just let me know and we'll bump off the edge of that. But I've always been curious about how you all handle the metacognitive part of training, right? So there's the detail part of training. Here's a patient who's maybe having a stroke. Let's talk through the management of stroke. Let's talk through your algorithms, your things. But at the same time, as people are going through this exercise, they're learning about how they think. They're doing the metacognitive work of working on their own thought process. They're adjusting their virtual risk matrix or their connections between things, or however you want to think about whatever neural net stuff's happening for them, literally and figuratively. How do you all incorporate with that? How do you help them be reflective about their thinking? How does that factor into the design?
Yeah, no, that's a great question. And I think that's one aspect we really pride ourselves on as it relates to other types of resources. You might learn from a static textbook or a question bank. You get used to in medical training, in training in general, exams and questions and getting towards the right answer to something. But medicine is so much more the practice of not just shouting out, it's appendicitis, but knowing all the different things that go with that, from the antibiotics to the interactions with the surgeon, to the CAT scan, the order of operations of how you ask questions, how you do your exam, what order you perform your testing in. And I think the structure of those cases really it lends itself to draw that out from people. They are excited to make the diagnosis. They want to get to that answer. But what we really support you in doing and force you to do is also think about all those other facets of it. In a patient with abdominal pain, don't you need to also think about potential GU causes? And do you need to do an exam or not? When you're talking about a respiratory complaint, what other aspects might be relevant, like examination of the legs, totally separate, looking at edema, looking at calf pain and potential DVT. And then when you go into the testing, what red herrings might be out there? Did you check a glucose before you took care of that stroke patient to understand if it was a mimic and not really a true stroke? And when you wrap that all up together, walking through that kind of case, you do get to the diagnosis, that aha moment of what's the final answer. But you also have to think through all of those potential off ramps or judgment calls and the order in which you do things that go into the full comprehensive practice of medicine and what's so challenging about becoming a new attending and practicing in the field.
Yeah. Hard, yes. There's a lot of complication in there, and it is much harder than just, oh, I'm applying this one rule of thumb to this person's sort of presentation to figure out what's happening, right? There's this sense of, yeah, really operating under deep uncertainty, right? You don't know what you don't know. You don't know the details of what's going on. You have some mental models and tools to work with, and you're discovering and operating at the same time in it. Love that it guides you through that process. There's another model that we use that around this is based in emergency medicine, which is like the oral boards model, right? And the oral boards model, if you're listening to this and you've never gone through it, it basically mimics a lot of what Josh was talking about, but just from a pure verbal standpoint. Like maybe there'll be a sheet of paper with some numbers on it or a picture of an x-ray, but most of the time it's people, two people engaged in a back and forth conversation with some sort of a challenge discussion. All right, Joshua, we're not going to do this. Don't worry. I'm just giving an example. But whatever your old man comes in with symptoms of XYZ, and your job as the responder to that case is to talk out loud through your thought process and to name the things that you would do. So I would ask for an IV to be placed and the patient be hooked on the monitor. And what do I see when I walk in the room? And you're like trying to vocalize what you're doing. But you bump very quickly into this concept of work as imagined versus work as done, or I guess in this case, it would technically be work as described as opposed to work as done, right? So it doesn't really mirror the real life scenarios that you find yourself in. It also doesn't usually give you necessarily the feedback, right? If you think about how do you learn some of this stuff, you really need the feedback loop. You need a sense of, did you arrive at the right point, but was the path that you took to get there useful or wasteful or potentially dangerous, and you still landed at the right point for it, right? So when I went through oral boards, I remember being like, I want to know not only what the answer was, but what did this other person who's judging me think of my thought process? And there's not like that closed loop for it. I know you've gone through oral boards, and most of the people that work on the team with you have. Like, how did you all design it to make it better than that? What are the processes that you'd put in place to make it not just more interactive, but also like just a better way to actually teach this stuff?
Yeah. I don't know. Even for me with that experience, the mention of oral boards raises my heart rate a few ticks. It's a very challenging experience. And you're right, especially to walk through it in that way, which doesn't exactly your map onto real life experience. I had a fairly unique experience of the oral boards too, hopefully not to repeat itself, which was that it was during COVID, so it was canceled, and I needed to do it then on a Zoom format. So I sat with sweaty hands and my camera on, doing the cases, and then waiting several minutes in between with a black screen to jump between case to case. It was a very challenging experience, but it went fine in the end. But you reminding me of that and what a unique format that is. But yeah, there's so many aspects of it that do try to push you to bring out that thought process, but you don't actually get that feedback. You don't get the insight into where did I go wrong, where did I take a funny swerve, and where did I do something extra that didn't need to be done. So that's something that's really baked into how we build those simulations. And every one is written by a practicing clinician, then reviewed by at least two others. And it's built to tell you every action that you did, whether it was good, bad, okay, didn't really matter, didn't really add anything. And then each of those has its own explanation. So when you get to the end, you get a score, you get to see exactly which components were necessary, which were just extra, maybe didn't need to happen. We scored on critical down to harmful with neutral in between, and feeding that back in and then repeating a case and iterating on it, trying to get a perfect score, not because there's any exact perfect way to do it, but to understand that there are always going to be pieces that aren't really adding value. Maybe it's done because it's routinely done. Maybe it's something that doesn't really give you more information, or maybe there's parts that are extremely critical and weighted much more than other pieces of the case. So that's how we build each one, and each case has this complex rubric behind it and explanations for all of those actions, so that you get to apply your thinking, and then you get to see which of those pieces were especially important, which were maybe missteps or just detours that didn't add much to the value of the management.
I'm going to ask this question, and it sounds like it's an easy question, but I wrestle with it sometimes, and I don't think it's that easy. How do you know what actually adds value to care? Because it's one thing to be like, oh, I'm matching my actions to what a board of experts would do, which is good, but it's not necessarily like deconstructing. It's not necessarily capable of deconstructing that except for looking backward. And there's some things you think about a critical action. There's a patient in front of you that has an arterial bleed. You should pretty much almost always put pressure on that thing, right? Like you should try to stop the arterial bleed. Like that, there's parts of, if you just look at the landscape, like there's situations where there is an unambiguous best or right answer based on your knowledge set at the time and your tools that are available. But then most of that landscape that we're exploring in a crisis, like we don't really know. Like we know what might move us in a better direction or a worse direction. And as we get close to some of these places where there is a right answer, then it becomes a little more obvious, right? So you can imagine if we take a complex adaptive systems lens, we're describing an energy landscape with the concept of an attractor, which is that as there's this thing, and as you get closer to this thing, you're more likely to get closer to this thing, and it like a gravity well picture, right? So the more the case evolves in certain ways, the more your knowledge changes, the more likely it is that there is a correct answer at some point. But in a lot of places, we just don't really know what the right answer is. And so there's some judgment about this. And I don't know, how do you all think about that? How do you, like, and you can answer that like from a structural point of view, from full code, or you can answer that from a Joshua point of view, how do you think about it? Or from a philosophical point of view, like how the hell do any of us think about this? Like we're operating under such uncertain conditions. How do we know what's right?
Yes, yeah. And that's one of the most interesting and complicated aspects of practicing medicine, is that there are some things that we think of as being absolutely correct. Once you go into practice, you start to learn that there's so many of those that that actually means is this is what is typically done in the United States at a tertiary care center with subspecialists. It doesn't mean that it's good necessarily. It doesn't mean that it's the exact right action. And there's some things we certainly know are helpful, like aspirin in a heart attack. But
Mhm.
once you start going down the line, there are so many medications and other tests that we do where it's a little bit unclear what's a good idea and what's not, even if you start to drill into evidence. That's something we certainly think about as we build the cases. And that's why that's helped me refine my thinking. And we start to put them together and realize that certain things that we always do or often do are more a matter of routine and not really useful. And so as we build a rubric, we'll score that as neutral and say, you know what, that didn't really do much. And somebody might say you don't need that. Somebody might say you do. And that's okay. And we're going to give you a pass either way. It's still hard to capture all the facets that might go into it. And we get feedback all the time with people giving different perspectives and different practice environments. And we adapt the cases accordingly. And that's something that's also informed my experience doing legal consulting work as well.
Totally.
Just looking at deep into the typical practice and the evidence base around some of the routine decisions that we encounter day to day, we realize that a lot of them have a very shaky underpinning, and that's more based on tradition and local practice pattern than it is on rock solid science or interventional data. So it's all of those have been really eye-opening experiences as I dive deeper into medical decisions in both in full code and as an expert consultant, just to understand that there's so much gray out there, and that really is the art of medicine.
Even that, okay, this is great. This is where I was hoping we would go, is overlaying these layers of like how much of medicine is learnable and what, like, where are there right answers versus not, and how do we disentangle those spaces? But to your point about like giving an aspirin during a heart attack, like certainly I agree, right? And it's easy when somebody surfaces that question. I have patient in room 6 who has a heart attack. Would you like to give an aspirin? And usually, with some exceptions, right, the answer is yes. Like the default answer should pretty much be yes to that. But what's a lot harder is getting at, all right, when you believe the person has a heart attack, is having a heart attack, then you should probably give them aspirin unless there's a contraindication. But when do you switch your belief pattern over into that? How much belief is the right amount of belief? And when do you think it's happening versus not, and the risk benefit of these trade-offs? And my friend and the neuroscientist Zab Johnson talks a lot about in the brain the speed accuracy trade-off of decision making, right? You have some threshold where your amount of belief about whether this sphere in front of you is a beach ball or a pumpkin, right? And you have some amount of belief that adds up, and then eventually your brain decides what it is and you've gone that way. Are you more interested in rapidly deciding beach ball or pumpkin? This is a terrible example because why the hell would you ever need to do that? But you just stick with me. Are you more interested in rapidly deciding, or are you more interested in correctly deciding? Because it's not, there's some degree to which that's a zero-sum game, especially when you start bringing in teams and systems and things. We think all the time about not just simple questions like, does this person need an aspirin? But the complicated next step questions of, should I wake up an interventional cardiology team at 3 a.m. and bring them into a hospital in order to try to intervene on this person, still not knowing what the answer is, right? Because most of the time we aren't in a place where we have the luxury of gathering enough data to be totally certain before we make certain types of decisions, right? That's one of the reasons that emergency medicine is so challenging and fun and interesting. So doing the best you can with what you have, and you just keep butting into this problem of like, how much can we know? How much certainty do we need? How do we teach that? How do we train that? How do we judge that after the fact? I have a million more questions, but dealer's choice, if anything I said in there sparks a thought that you want to go after. Otherwise, I'll pick a direction. But
No, absolutely. It's certainly it's a day-to-day part of my practice, the sort of fast and slow thinking and trying to toggle between those and use them to the right amount because we're under a lot of time pressure and a lot of multitasking pressure. And there are certain kinds of diagnosis where the stakes are maybe lower and the pattern recognition is a little easier. A lot of times, someone with a kidney stone, I just poke my head in, say, "Yeah, you have a kidney stone." We're gonna do some other stuff, but it's very clear, and that's just a split second. But then there's always someone during the day that really requires you to unpack so much more of the thinking. Someone with a really funky headache and some strange neuro symptoms, and how far are you going to take it down that rabbit hole? One of the things you learn by the book in residency is that if you have a fever and a headache, then you need a lumbar puncture. That's the right answer. But all day long, people come in with all different kinds of headaches and sometimes fevers or infectious things. And you really do have to decide how often you're going to go down that rabbit hole and unpack it. And that's one of the trickiest parts, because you can take a really good history and you can look at them, and then you have to make a decision, because it's a CT and an invasive procedure and then waiting for a result and maybe empirically treating them and then bringing them into the hospital, or sometimes none of those things and sending them home. And that's one great example of just how that thinking has to scope out and how many little judgment calls you have to make on any one given patient.
Yeah. Yeah, absolutely. We've talked about this in the context of like, where can you learn things? Where are there right answers? And we've talked on the podcast before about this under the sort of the heading of like, where can you develop expertise? Like, where is the universe repeatable and learnable enough at low enough cost of learning that you're capable of actually developing expertise in that space? And I think one of the reasons I love the idea of full code and what you all are doing is that where there is that capacity to develop expertise, you're building a way that allows that expertise to be reached quicker, safer, and like more easily. And that's awesome. I think it's an interesting balance about where those lines are around what you can and can't be an expert in, actually. I don't have answers to this. I just wrestle with this on a regular basis, right? Like, how much of medicine is actually expert systems and how much is just really not? Because we don't know, we can't know, we don't have the tools to know, and we're just like doing our best. I guess I'd ask, as you've been doing more of this expert consulting from a legal point of view, how has that changed the way you're wrestling with some of these fundamental questions, if it has? Objection.
Yeah. So, yeah, it really gives you an opportunity to slow down, look very, very closely at what decision making happened, in what order, and to zero in on the things that are actually more critical for helping someone or making a diagnosis. I think it's so easy in day-to-day practice to really get drawn into the typical practice and what pieces always happen because they always do. Because we have a triage-based system in my hospital, almost everybody gets a CBC and a BMP, and for pretty much anything except stubbing their toe. And that's much more a part of just practice and trying to operationalize and get people through quicker. But drilling down into what are the parts that people actually need, there's setting aside that there's equivocal evidence on a lot of intervention. We talked about that already. Even so, even if you take at face value that there's certain key things you do for certain kinds of presentations, whether it's TNK for stroke, whether it's PCI for acute coronary syndrome, most patients, there's maybe one or two things that you do for them that are really critical. A specific antibiotic choice, a specific call to a subspecialist or surgicalist,
Sure.
and the rest we do as routine and to be comprehensive. But when you get down to it, there's a lot of labs, there's a lot of EKGs, there's a lot of imaging that's not particularly moving the needle. And you really have to drill down into what's critical for the patient. And I think that's what some of the work has taught me, especially because some of those things are easy to forget in the heat of the moment. And I'll give you an example. I see lots of patients that don't speak English well, and or don't speak English at all and have another primary language. And in a very busy day and in a very busy emergency department, it's easy to forget one of the core fundamental things that you need to do is understand their story and ask them questions and understand their answers clearly. And so some of that in reviewing a prior case really changed my practice around interpreters, especially. Have them, use the best one that you have available to you, and get the really good, high quality story just like you would in your native language. And that seems so obvious when you look at it in the abstract. or you're sitting outside of a shift. But in the moment, it's so easy to push the issue or rush or not, or cut corners in that domain in particular. And so that was one lesson that I definitely took away. And it's so simple. What am I doing for them? I need to know why they're here and what's going on and what's worried and alarmed them. And if I don't have a good grasp on that, I don't really know how to do anything else. And I shouldn't, and I'm not going to necessarily get the whole story. So it pulls out some of those fundamental truths about it. What do I need to do for this patient? I need to understand their story. What do I need to do for the confused patient? I need to understand if they have capacity, what decisions they can make, if I need someone else to make decisions for them. And then when it comes to the diagnostics, what are really the key elements? And it's very easy, I've seen in cases I've reviewed, to lose sight of there's the one key intervention that needs to happen. And there's all this other stuff that we're waiting on or trying to do. But if you don't give that intervention or call that specialist in to care for the patient, that's where things go really wrong. It's just losing the forest for the trees in terms of your decision making, which is so easy when you're in this soup of multitasking and rushing and trying to get through the day.
Yeah, it's also always easier to see retrospectively, right? Like when you have the story, then you can piece together, oh, this was the key intervention for it, right? But unless you've operated in one of these spaces, you don't realize how little you know about what's happening in the moment most of the time. And so you're faced with this, what's the cone of possible futures? What are the possible critical interactions? And then where do I need to assign resources to make that space? But fundamental to that process is, like, in my mind at least, is being really honest about where you're an expert, and then also what you don't know and where you're not. Like you might still be the best in the room, but that doesn't mean you have like expertise about this space around it.
I think one of the things that I grew to be more comfortable with the more I practice, but is tricky to get your head around, is that you're not really firmly and definitively ruling things out most of the time, accepting a tolerable level of misses, that maybe it's 1% or a 2% chance. And that's generally what we agree might be okay. But it's not possible to perfectly rule anything out. And there's always that possibility that something's going to slip by, and even the diagnostics that you're using. And that's one of the things that you have to also get comfortable with. And my legal work has certainly informed that. Just because everything looks fine, sending people home with the return precautions and the instructions of what to do and when to change course and when to come back is such a critical piece as well, because there's always going to be that sliver of things that you're getting a snapshot at a time where everything looks okay. And then a day later, it doesn't. But if they don't know what to do, they may not come back. And I think that's a hard concept too to get to patients. You're not 100% fine just because we had negative tests. But that's it. That can be hard to convey.
Uncertainty is slippery and challenging, right? Sort of operating within that space of uncertainty. And then like you start stacking uncertainty on top of itself, and you end up with some pretty interesting constructs and things that happen out of it, right? I remember going on this quest at Mass Gen when we were both working there, like way down in this rabbit hole, talking to technicians in our laboratory about what the standard error was on our sodium measurements, right? Because you'd have these patients that would be hyponatremic with low sodium, and you would need to adjust their sodium at a very certain rate. And you'd make all of these decisions as the sodium numbers came back differently. And I would always be like, but is that really like a real difference? Or like, if number A is here and number B is here, and there's this wide spread of what possible truth is around it, like, how do you know if you're making a right call or not? It was mostly informed by our medicine colleagues that I didn't understand hyponatremia, as opposed to like digging into the uncertainty underneath it. And I just don't know if that's true or not in retrospect, but I think it's very comforting to act as if there is certainty when there is not. The counterpoint to this is, of course, the speed accuracy trade-off, right? There are times when what you actually need to do is move and do something and then pick up the pieces about it later. And to have the ability to recognize those decision points about, look, I don't know what this is, but this person has to get this thing right now. and to not need certainty to act, but also to not pretend that there's certainty when there isn't, are very interesting and very challenging skill sets. And I like the way that you all are doing it with the full code. I think it's a challenge to figure out how do you score and judge somebody on a system where it's maybe impossible to know what the answer is, right? And the best you can do is be like, most of us do it this way.
Yeah. Yeah. And that's something we spend a lot of time baking into the scenarios is that idea that there's probably a whole bunch of things that fall into a neutral category, that some people do it over here and they don't do it over there. And some people will have a different assay than others. And some people might use a different combination of antibiotics, and to try to put as much of that into each case so that you can really understand, okay, this is critical. And we know it is because it's been really well studied. And we know that there's a mortality benefit. And this is recommended because maybe you're going to help with a symptom, but you're really dealing with an acute situation. So symptom relief is a secondary priority. And then maybe something is off the beaten path, and even you're using time or resources that you don't have. So it's going to give you a ding, but it's not necessarily wrong in a way that it's harmful. So that's something that we could go very far into parsing out, and we don't. It's still a 5 got on the Likert scale.
Sure.
But to try to capture a lot of that stuff in the simulations, because that is the bank of knowledge that you need to develop across the course of experience with patients. For a long time, it was just real patients. That's the only way you got it. And more recently, much more in simulation, and we're a part of that tapestry. But there is not necessarily, in many situations, an exact textbook chapter to point to or RTC that definitively answers the question of what you're doing and whether it's a good idea. So we try to bake in as much granularity as possible to help people understand that about the equivocal nature of so many presentations.
Yeah, I think I'm going to call this episode Experiential Learning with Uncertainty, right? Because I think that's what we're talking about, right? Is this idea that you get used to wrestling with the uncertainty, and you do it in a way that's, like you said, not real patients. That's cheaper learning from the sense of the suffering, not cost, although probably cost too, right? But like you're getting to a place that approaches our best knowledge set, whether or not that's true expertise or just the best tool that we have in the box. And you're doing it through this experiential loop of practicing in quasi real life scenarios. And you're doing it with uncertainty, right? There might not be real answers to it. And I don't know, it's humbling sometimes practicing medicine. You have all of this advanced knowledge, the best knowledge that humanity has, and you're still sometimes, I don't know, it's probably this, right? Like, this is just the best that we've come up with as a species. Like, it's probably this thing. And what do we do with that? We usually do this, right? And that usually works. And sometimes it doesn't. We just don't know. And the amount that we don't know just dwarfs the amount that we do know. Maybe AI and the singularity will take care of that for us as we keep advancing towards that. But
well, thanks.
Yeah,
I think that's very much on point. There's so many surprises that we still encounter, even as you have more and more experience, seeing more and more presentations. You'll get more of that pattern recognition. You'll understand more presentations that you can really get to quickly, really understand what's going on, but you'll still see people that just make you scratch your head. And that's the richness and the challenge of practicing medicine and emergency medicine, especially. I had a patient recently who was dizzy and didn't feel good, and their sugar was high. And then I just started going down a rabbit hole, checking things, and they got more concerning until I just did a CAT scan. But I did a CAT scan in the way an emergency doctor sometimes does a CAT scan. Let's see what's going on here. We got this thing, we could take some pictures. And final diagnosis, closed loop bowel obstruction with ischemia.
Huh.
And that's emergency medicine. You'll stumble into these strange surprises all the time. And I think one of the things that we can capture some of in full code, but is still so tricky in general, is not just the which diagnostics do I do, which order, but there's so many layers to it. There's also the resources that take those tests. For example, respiratory runs a VBG, but what if they're over here working on the vent that VBG doesn't happen? And what if a patient really needs a CAT scan right now, but they don't have a creatinine? If you sit there and wait, the policy of the institution will wait on that CAT scan, but you can also push the person over. You can talk to the CT tech that you know well. And there's interpersonal and operational levels that you have to get into as well in taking care of patients and trying to do the right thing. Because even if on paper you're trying to execute the plan that you think is appropriate for them, you still have to deal with the human factors, the operational factors, constraints, lab machines being down, people being on break. There's all kinds of different that go into navigating that successfully.
Yeah, real life is messy, especially in an emergency department.
Absolutely.
There's a lot of opportunity for development and growth in that space for sure. Joshua, we are nearing the end of this, and I want to give you a chance to issue a challenge to folks listening to this. Anything you want them to do differently or better after listening to this episode. While you're thinking about that, I will give our normal disclaimer, which is that our job here on the Emergency Mind podcast is to take the best of what other people and teams have learned about applying knowledge under pressure and to share it with the world. Nothing we talk about here is medical advice. And all of us, myself and my guests, represent only ourselves and not anybody that we work for or with. Disclaimers aside, what do you want people to do differently after they listen to this episode?
Well, I think for me, one of the hardest transitions to make from student to a practitioner, something that full code has taught me a lot about, and first years of being an attending as well, was really that very difficult shift between trying to get to the answer and being right, which is the joy and the reward of being a student. You want to get a high score, you want to be correct, you want to get to the diagnosis, you want to shout the right answer on rounds. And that's really trained into us and baked into a lot of our personalities. But the big transition and leap that you need to work on and practice, and full code certainly one of many tools to do that, is to think about it in a very different way. I'm not trying to be right now with this one person. I'm trying to do a good job for every single chest pain patient I see every single day, all year round for years, and be comfortable with the level of conservativeness or that I'm bringing to it and how I'm going to work that up. That you're going to practice in a way where you're consistent and you don't miss things, and you bring that curiosity and intention to each of those interactions over time, because it's no longer about, I was right, it's appendicitis. It was totally appendicitis all the time and I got it. It's so much more about, you're going to see hundreds of belly pains and so many different varieties that you need to be bringing that different attitude towards it, that you want to do well for all your patients over time, and which is such a mental shift that you have to bring to practice.
I always think about the integral of your work over time, right? You want to aid society from being there. And what's the integral of your work over time? I think that obviously you want to be right for each person individually. There's a bit of an ergodicity problem in that, but you want to think about the integral of your work over time and to be a net positive force for the universe. So that's a great way to describe it, Joshua. Thank you. And thank you so much for coming on the podcast, for joining us, and for sharing your wisdom and learning and depth of uncertainty about all of this.
Thanks so much for having me. It's been great. Thanks a lot, Dan.